Hello, everyone, and welcome to The Explainer. Today, we're diving into a really fascinating and honestly, absolutely critical area of pediatric medicine, congenital external genitourinary defects. We're going to walk through exactly how we manage these anatomical challenges, starting with the super common, easily fixed stuff, all the way up to some of the most incredibly complex reconstructive surgeries happening today. It's a real journey through human anatomy, some amazing surgical innovation, and of course, compassionate, lifelong care. Let's get into it.
Here's our roadmap for today. We'll start with a broad look at pediatric genitourinary defects, then dive into the causes and types of hydroceles. After that, we'll tackle the exstrophy epispadias complex, review the surgical repair approaches, and finish up with nursing and home care. All right, Section 1, Pediatric Genitourinary Defects. A broad look.
You know, any defect involving the external genitourinary tract carries a pretty heavy emotional weight. For parents, it's understandably distressing right from the start. And as these kids grow up, congenital defects like these can really distort their body image. But, and this is the bright spot that's going to anchor our whole discussion today, early, modern surgical repairs are incredibly successful for the more common disorders. We intervene as early as possible, and that really sets these kids up to live healthy, fully functional lives.
Moving right along to Section 2, hydrocele, causes and types. Okay, so let's define exactly what we're looking at here. Basically, a hydrocele is just the presence of peritoneal fluid trapped inside the scrotum. Specifically, it's sitting right between the parietal and visceral layers of the tunica vaginalis. This is actually the #1 most common cause of painless scrotal swelling in kids and teens. You see it all the time in newborns. But the great news? It very often just resolves completely on its own by the time the child hits 1 to 3 years old.
Now, there's an important mechanical difference between the two main types you'll see. Think of it kind of like a plumbing issue. With a communicating hydrocele, the processus vaginalis doesn't close up during development like it's supposed to. That leaves a literal open pathway, a communication, straight to the peritoneum. Because of this, the fluid can actually change in size from midday, like when the baby strains, and it's reducible. On the flip side, a non-communicating hydrocele has zero connection to the abdomen. That fluid comes straight from the mesothelial lining itself, so it doesn't change size when the baby cries, and you can't reduce it.
So the crucial takeaway here is knowing when to actually step in. While a lot of these just go away spontaneously, surgery is definitely indicated for those communicating hydroceles if they persist past 1 year of age. Why? Well, because that open pathway is a major risk factor for developing an incarcerated inguinal hernia, and we definitely want to avoid that. The surgery itself is a really straightforward outpatient procedure. Post-op care is super minimal, mostly just telling parents to keep the kids off straddle toys for a couple weeks so everything heals up nicely.
But what happens when the developmental anomalies are, well, much more severe? What actually happens when the abdominal wall itself completely fails to fuse while a baby is still developing in utero? That brings us to Section 3, the exstrophy epispadias complex.
Let's unpack these intimidating medical terms a bit before we get into the clinical reality. Epispadias just refers to an exposed or open dorsal urethra. Bladder exstrophy, though, is a much more severe defect. We're talking about an open, literally inside-out bladder, where the inner mucosal surface is completely exposed right there on the lower abdominal wall. And this usually doesn't happen in isolation. It's often paired with other genital defects and a noticeable widening of the pelvic bones.
When you look at the clinical presentation of this, it's pretty stark. You have the epispadiatis opening, and alongside it, you can clearly see this bright red, everted mass of the bladder exstrophy resting directly on the newborn's abdomen. Basically, because the abdominal wall and the underlying structures just didn't fuse, the lower urinary tract is entirely exposed to the outside world.
And as you can probably guess, the complications here cascade incredibly fast if we aren't meticulously managing it. Because the bladder is completely open, urine constantly seeps directly out of the exposed ureteral orifices. All that constant moisture on the surrounding skin, it causes really painful tissue ulceration. Plus, the area becomes malodorous and is highly prone to infection. If we leave these ascending infections and obstructions untreated, it's a direct path to progressive renal damage and eventually potential renal failure.
Now, we also have to touch on the absolute extreme end of this spectrum, cloacal exstrophy. This one is incredibly complex because it involves not just the urinary and reproductive tracts, but the large intestine is also exposed through that abdominal wall defect. The silver lining here, if there is one, is that it is exceptionally rare, happening in less than 1 out of every 100,000 live births.
So, how do we fix this? Section 4, surgical repair approaches.
When a surgical team looks at the extrophy epispadias complex, they are essentially trying to balance 5 massive therapeutic objectives. First, preserve renal function. Second, attain urinary continence. Third, provide a cosmetically adequate reconstructive repair. Fourth, prevent those devastating UTIs we just talked about. And fifth, preserve optimal external genitalia for future sexual function. It is a massive, highly delicate reconstructive balancing act.
Currently, there are 2 main ways surgeons tackle this. First, you've got the modern staged repair of extrophy, or MSRI, which breaks the whole reconstruction down into typically 3 sequential surgeries over a period of time. Conversely, the complete primary repair of bladder extrophy, or CPRE, is this highly ambitious, single-stage closure done very early in the baby's life. Now, remember that widening of the pelvic bones we discussed earlier, the diastasis? Well, in both surgical approaches, surgeons frequently have to perform pelvic osteotomies. That means they literally have to cut and reshape the pelvic bones to close that gap and take the physical tension off the delicate abdominal repair. Finally, let's look at Section 5, Nursing and Home Care. Before the surgery can even happen, or if, for some reason, a child is sent home with an unrepaired defect, the nursing care sequence is absolutely critical. Think about it. You absolutely cannot put a standard diaper directly over an exposed bladder. The fabric will stick right to the mucosa and literally tear the tissue. No way! Instead, the exposed bladder has to be covered with a non-adherent plastic wrap to safely keep the moisture in. Diapers are changed constantly to manage the seepage, babies get sponge baths instead of being submerged in water, and we monitor them like a hawk for any signs of infection. Once the surgery is done, the post-op phase is, frankly, intense. Because the surgeons have just pulled the pelvis and the abdominal wall together under a ton of tension, immobilization is absolutely critical to prevent wound dehiscence, which is the surgical site tearing back open. To stop that from happening, the child's pelvis is usually immobilized using traction, like a modified Bryant traction, for 2 to 4 straight weeks. It's tough. Pain management and keeping them hemodynamically stable are the huge nursing focuses during this recovery period. And the care doesn't just stop once they leave the hospital. Not at all. This requires lifelong, multidisciplinary team care. The parental stress is just immense. And as the child grows into adolescence, getting them psychological support is absolutely vital so they can develop a positive body image. Also, if full urinary continence isn't achieved after everything, families, and eventually the kids themselves, are taught clean intermittent catheterization, or CIC, so they can manage their bladder health independently. Which really leads me to a final thought for you to chew on today. As our incredible surgical techniques keep getting better and better at perfecting the physical outcomes for these kids, how can our healthcare systems evolve to better support their lifelong psychological and emotional adaptation? Fixing the anatomy is a monumental achievement for sure, but healing the whole person, that's a lifelong journey. Thank you so much for joining me on this deep dive, and I really hope this explainer leaves you with a profound appreciation for everything involved in pediatric urology and nursing care. Catch you next time.